Hello, and we welcome you to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. The series has published for over 100 years, and today for our second podcast, we are discussing the April 2022 issue on head and neck surgery. I'm John Vassallo, the managing editor of the series here at Elsevier, and this podcast will focus on 4 of the articles in this issue: airway management in the head and neck patient, esophageal dysphagia, management of primary hyperparathyroidism, and the image of the online physician. The discussion will be led by our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editors of the head and neck issue, Dr. Brian Mitchell, from the Multicare Rockwood Clinic ENT Center in Spokane, Washington, and Dr. Kyle Tubbs from the Glacier Ear, Nose, and Throat Clinic in Kalispell, Montana. Welcome to all 3 of you, and over to you, Dr. Martin.
Thanks, John. Appreciate it. And Dr. Tubbs and Dr. Mitchell, welcome to you both. As John mentioned, this is our second iteration of the podcast, even though we've been publishing this series for now over 100 years, and I've been at this for about 20 years, but appreciate all the effort that you guys put in on putting this series together. And sort of head and neck surgery is one of those areas where general surgeons and our ENT colleagues, and to a certain extent our neurosurgery colleagues, overlap quite a bit. And we really appreciate you guys giving us your specific insight. I think it means a lot to general surgeons across the board, but also in some of the more austere regions where people read these. We picked the 4 chapters that you guys asked to discuss out of this issue. I think they're all going to be a tremendous interest to our readership, but I was hoping, if it's all right with you guys, that we'll start off with the airway management issue. I guess ABCs is common in surgery in general in medicine, but we'll see if we can do the same thing with this series. But this is from Dr. Wandel et al. And I'm throwing this out. Please, either of you feel free to respond however you want. This is pretty conversational, but the chapter itself focuses predominantly on airway management in the head and neck cancer group. But I was wondering if either one of you would like to just give us sort of your general thoughts on, overall thoughts on complicated airway management, surgical operative airway management in general, and then maybe we can get into some of the specifics from the article itself.
Sure, I could start out. And I think you're right. This is a place that the otolaryngologist and the general surgeon will overlap, especially depending on the hospital system or community that you're in. And this focuses, on the management of head and neck cancer patients, but that can pretty easily be extrapolated to any patient who presents to the emergency department with upper airway obstruction. And this is certainly a place where a trauma surgeon will often be involved in a person's care. A person comes to the ER in shortness of breath, they're stridorous, there's concern for upper airway obstruction, maybe a CAT scan shows that, and they may be asked to help manage the airway in this patient, oftentimes in consultation with an emergency room doctor and anesthesiologist. But it's important for the general surgeon and certainly the otolaryngologist to know what options are available as you're dealing with this person with a tenuous airway. As you mentioned, A is the first thing in our algorithm as we're evaluating critical care patients. And so knowing what options, what tools are in your toolbox to help you establish a safe and effective airway in this patient, I think is so critical. And so that's, I think a reason that this is a very important topic for both our specialties.
I would second that, having been in practice for a long time at a large tertiary type center that was academic in types of acuity and complexity, but not a traditional academic center. Airway quandaries seem to come up, multiple times a week. And I think if there's a practical lesson for me, it's just attempt to plan ahead if there's any opportunity. And usually that doesn't have to be anything more than, I think, a cursory view of the patient. And does this look straightforward, or does this look like this may be trouble, knocking at the door? And it's been interesting to me to work with surgeons and anesthesia providers both who are on both far sides of that coin. Extra planning ahead, you know what I mean, as so far as to even get a hold of whoever's on call for ENT or grab one of us that might be operating. And then those that are kind of a little bit more cowboy style in terms of, I think we'll get them intubated. Let's not get too concerned. We're worried about what's going on with the extremity or the belly or whatever the case may be. And I think it's those phenomenons where you're sort of caught flat-footed that become the crisis, or the one that really, could be a bad outcome in a person's career. I think especially people who have odd body habitus, whether that's as simple as obesity or it's just the elderly kyphotic patient, and then patients who have had radiation of the head and neck, and they just oftentimes will have that stiff, woody characteristic, particularly those that are years out from the radiation. And you can kind of just surmise, boy, I bet this is not going to be easy. And a lot of times just putting your hands on the patient's neck ahead of time if there's anything in doubt. And if that is just, stiff as a board, suffice it to say, you're probably going to have a symmetric appearance of the larynx, and you're probably going to have a struggle on your hands. And I think it's in that preparatory phase that, in conjunction with the anesthesia, and the article kind of lays this out, just a sort of an algorithm of plan A, B, and C as to how we're going to go about getting the patient, anesthetized to the degree that's needed, and hopefully not experiencing the so-called crash surgical airway that we've all seen that come up on occasion. But I think the more times you can limit that in one's career, the better it is, at least for your blood pressure, in my experience.
And knowing what's available at your hospital, what resources you have, what colleagues you can ask to assist. These critical airways, in my experience, are always a situation where more heads is better than one. To get input from an anesthesiologist about what medications are safe in a given patient, to have your emergency room doctor, your emergency room nurses available to assist, do you have a flexible endoscope you can use for fiber optic intubation? Do you have a video laryngoscope available in the emergency room? Having your surgical airway, whether it's a cryoc or a tracheostomy kit, ready to go, having little things that we maybe don't think about in the heat of the moment, having suction, having good lighting available, having appropriate instruments, all these things, anybody who's going to take call in emergency room from a either general surgery or otolaryngology standpoint really needs to be familiar with what resources are there when they get called for that, which hopefully doesn't happen often, but when it does, you want to know where all your stuff is, and you want to know it now.
Well, I mean, that brings me up to sort of a point that both you and Brian have alluded to, and sort of going through my notes on this was sort of to have a little discussion about the plan versus the unplanned airway. And there are people who find themselves, particularly in austere environments, and when I think of like the time I spent in Afghanistan and Iraq, you don't always have brilliant ENT colleagues like you guys handy by. But we do spend a lot of time training our crews, especially those who are going to deploy to combat areas, on being able to establish surgical airways, operative airways, and being able to know where the gear is so that you can do it over and over again. I haven't found back here in the States, in the civilian sector, that people necessarily go through the same level of training on a routine basis. It's not that they don't do it all, but they don't sort of do it often enough that everybody sort of finds it second nature. So, planning and being prepared for disasters is obviously best. But what's your observations and your recommendations and your thoughts to give people when they get dragged into something unawares and somebody's tried something and suddenly the situation's turning sideways and you've got to intervene? What are your particular thoughts on that?
I think the first thing I always think about, Ron, is achieving an anesthetic at that very moment completely necessary for the patient. I've dealt with a number of airway disasters where the airway disaster arose during the induction phase of anesthesia for something that by and large was completely necessary, but completely elective. And it's amazing to me how often let's not over sedate, don't paralyze the patient with drugs if you don't think you're going to be able to bag them. Like that simple rule that I think most of us, at least here in the US, got exposure to in med school. That one is first, always on my mind. And then can we just back out and just let the drugs wear off if you're not too far down a rapid sequence pathway, let's say, and just live to fight another day, so to speak, so they can have more evaluation. I'll see, and I'm sure Kyle does this too, we'll see several people, a year in our clinics where there was some effort at initiating an anesthetic incident, and whatever happened, and they were able to just ease their way out of it, arouse the patient and, send them for further evaluation, and then come back a second time to do whatever was the case that needed to be done, with a better plan. So that's the one I think of the most. I think if you have a life-threatening decompensation, at least in my mind, it's kind of like a different algorithm. Like you don't have an option to just, stop and back out.
And, I think you're right, 100% right, Ron, that it's hard to mimic, quote unquote battlefield conditions, here in our hospitals. All of us went through residencies that are rigorous, and most of the time those residencies are at high acuity trauma centers, and we certainly get experience or exposure to a lot of significant pathology. But you're right, it's hard to mimic what a person might get, say, in a war zone. But that doesn't mean we can't go through the same kind of mental exercise a lot of times and try to improve our experience. So we really have to think about this. We have to be able at the drop of a hat to kind of talk about different ways to manage an airway in a patient. So sometimes the things we forget are the most simple. Brian brought up earlier, masking a patient. Sometimes you'll kind of arrive on the scene of a patient who's trying to be intubated. They're having trouble. Maybe there's bleeding in the airway, whatever it is. And maybe no one's actually tried to mask this patient yet. And we can, if we just sometimes step back a little bit and start from the bottom again, the bottom of that algorithm, can we mask a patient? Can we get a laryngeal mask airway in? What are our other options as opposed to just going straight to intubation? And so it takes some effort. It takes mental effort, I think, on our part to really think through, read about, and learn these different airway techniques, even if we don't have a ton of experience with them. One thing in the fields of otolaryngology and general surgery, these instruments, you use them enough in other scenarios that you're comfortable with them, even if you don't always use them in an acute airway setting. And so it's just kind of applying skills that are used in one situation and using them in another. But we really do have to put some time, some effort into learning what's available and being able to be able to bring that to the front of our head when the time comes.
No, I think you're right. And I think as you and Brian have alluded to, one of the things they taught me in medical school, and it's been reinforced over the decades, is not everybody needs to be intubated, but everybody needs to be ventilated. And you don't always have to have a tube in there to make that happen. And I think particularly to Brian's point, I can think of any number of circumstances when I've been called into something, with everybody in a panic mode and just say, just back up. If you can move some air right now and you've got control of the situation, let your drugs wear off and let the patient had an airway before this began. Let's try to get them back to their original status, and we'll reconsider what our options are and decide whether we've got the right personnel, the right equipment, the right environment. But sometimes people just forget the basic stuff, like I could just stop here and not make it worse. So I think that's great advice, and I'm with you as far as the training bit goes. It's just, the federal government certainly has the capacity to make everybody do training and spend whatever time and resources they want to have them to do it. The private sector does a lot of great things, and I like working in both, but it just seems like you don't get everybody on board necessarily with some of these things in training mode, but it would be good to think about them and make sure that the teams work well. I think that's great advice. Last thing I wanted you guys to weigh in on the airway before we move to some of the other stuff is assuming the airways are all established, a little bit about the discussion versus early versus late tracheostomy in patients who are ventilator dependent for a while. In particular, it's a really well-written article, but a lot of the confidence intervals on some of these things bump up against one or cross one. So what are your thoughts on how do you determine who really needs to be trached? And then if they need to be trached early versus late, and what are your thoughts on that?
Well, I think it's a great question, Ron. I think it changed a lot over the past 2 years, at least here in the U.S. with the pandemic, to where for the first time ever, and I think Kyle probably would agree with this, we saw people intubated for way longer periods of time than we're used to. Having myself somewhat of an airway practice as part of my overall head and neck practice, I was always on the school of, if we think there's a healthy life expectancy for the patient, earlier versus later tracheostomy very often was in their best interest, so as to avoid, sequelae that are very difficult to fix. Laryngeal stenosis, particularly if it's posterior between the arytenoids, where you can get a scar formation and a stiffness that leads to vocal fold immobility, that is extremely difficult to fix, even at tertiary level expert hands. And similarly, other odd forms of scarring or webbing between the vocal folds. I've always been an early guy, meaning if you're at post-op day 5, let's say with intubation, or it's whatever, ICU patient on day 5, I'm immediately thinking, okay, if we can't get this patient a really good chance of being extubated in the next 48 hours, let's start the process of getting them on the schedule for tracheostomy. I think that's probably the biggest culprit I found over the years to people being intubated longer than you would prefer, is just lack of early planning. And there's a plethora of articles, at least on the ENT side, that look at institutions that have a lot of ventilated patients having some sort of a formalized algorithm saying, okay, by this point in time, we start the consultative process and so forth for the trach, so that by X date, let's say it's 7 to 10 days or whatever your decision is, you've already accomplished the trach, rather than it's been 2 weeks and now it's going to be another week to get the right guy to come by and do a consult, and the patient's on blood thinners, so we got to turn that off and so forth. And the next thing you know, it's been 3 weeks. Now, that being said, I have dealt with some patients here this past 2 years I had a couple of people that had been intubated absolutely too unstable to try to attempt a trach, well beyond a month. And surprisingly, were extubated, had some brief voice symptoms, but within a month or more of extubation, we're doing reasonably well without any profound sequelae. So it's been interesting to me to see that in real life against what I had always harbored as my worst nightmares, if you were to have that occur.
Yeah, I think I totally agree with Brian that it's better than, like most things in medicine or in life for that matter. It's almost always better to know early than late. And even if that's a phone call from your ICU doctor saying, "Hey, I'm thinking this patient might be down this road," maybe it allows me as the surgeon to start thinking about my schedule and, okay, if we're going to proceed on this, can I get it done later this week, in 2 days, in 3 days, as opposed to that phone call at 2 weeks. We want this patient to have a trach yesterday, and now you're kind of scrambling to figure out when to do it. So early communication is certainly helpful with our ICU doctors. I mean, the reality is a lot of this is kind of out of our hands, and that a lot of these patients that we're referring to are in the ICU for medical issues, ventilatory issues that we're not actively involved in their care. So we certainly rely on our colleagues in the ICU to help make a determination of what's this patient's long-term prognosis in terms of recovery and rehab, and what's that going to mean. Our own patients, our patients that we know about, the laryngeal stenosis patients, the tracheal stenosis, vocal cord paralysis, whatever it may be, then we play a pretty active role in deciding when to trach that patient. But otherwise, I think it's just having good communication, good collaboration with your ICU doctors, and just hopefully letting them know that you don't mind that phone call. That even if it's just, hey, just maybe have this on your radar over the next couple of days. It allows me to do some pre-planning.
Always nice to get a call in the daytime with plenty of time to think about something compared to the alternatives.
Kyle, you said something that I thought was really apropos in that early planning phase in the ICU. And this is something that's been a mystery to me with American medicine, at least, is that I have always wondered, and this started to happen with the COVID pandemic, why for prolonged ventilated patients, that when these people are critically ill enough to be ventilated and they haven't been extubated within a brief period of time, 24, 48 hours at the most, why we don't have more of a palliative care involvement, bringing these discussions forward with the family right from the get-go, or in my experience, even before the patient is intubated, when they're in the midst of critical illness, before it's even got to that point, saying, just walking the family down that road. Okay, if we go with intubation, especially with elderly people, where do you guys stand before we even get to needing a tracheostomy? Where would you even be if that's the case? And it's been amazing to me the number of times I come on board a patient that's been in the hospital for a couple of weeks or more, intubated, critically ill, and all not uncommonly, as the bearer of bad news with tracheostomy, so to speak, where that, sort of has a end of life hesitancy with a lot of patients, that's on the list of things they won't accept, feeding tube often being the other one. It's always curious to me how I'm like the first person who's brought up, like a life and death scenario and introduced like a palliative discussion, for the patients. And then very commonly you get that discussion going. And then there's all this regret and like, well, God, I wish they'd have brought this up. Day one hospitalization. We could have been telling you what, mom or dad wanted, in this predicament. And now here we are way down an avenue of treatment that the family's kind of looking at each other, wondering, how did we get here? And I'm certain we've all have dealt with that type of predicament.
Yeah, I definitely have, Brian. It's a really good point. And I think it really came into focus during the pandemic, especially early in the pandemic. You remember the early data that talked about, the really abysmal survival of COVID patients who were intubated. And so, at our hospital, palliative, and I think across the country, it started to become a trend that palliative care often was involved. And these kind of discussions were happening like in a much earlier phase. And, hopefully that's kind of made that a little bit more commonplace as we go forward, because, you're totally right. Even prior to COVID, there are patients that I think, we know as soon as this patient hits the ER, and certainly once they get to the ICU, prognosis is not good once this patient gets intubated, which doesn't mean that we don't, give them every option and talk about what we can do and kind of let them make an informed decision. But I think you're 100% right that information is very valuable to patients, and there are quite a few patients, at least in my experience, and families that presented with that information. And some, the reality is sometimes they know, they sometimes have a better understanding even than the physicians maybe, or those caring for them, that hey, dad's not doing well, and we understand that this may not go well, and it almost takes somebody stepping back and saying, hey, what would dad want? And where do we want to go from here? And that can be a good discussion to have at any time, but certainly early on in their care. I totally agree.
No, I think you guys are right. I mean, in my former job as a surgical educator and program director, we call that systems-based practice and practice-based learning. And they were core objectives of how we did things. But I think you're both illustrating one of the points that over the last 30, 40, 50 years of medicine, the fragmentation of who's involved in it has devolved away from the absolute ownership parts, and fewer people are willing to step up and tackle the long-term pictures because their engagement is measured in short-term units of time, shifts and maybe a week here or a week there. But you're completely right that if we want systems to work well, you've got to be thinking long-term from the day of admission. And you got to be thinking discharge from sometimes before people even get admitted to the hospital in order to make the system work correctly. And if more people did what the two of you have said, we'd probably have a lot less confusion and a lot less emotional difficulty for patients and families alike. So I couldn't be more supportive of what you're bringing up. One last quick thing on airways, just real quick. Any strong feelings about percutaneous versus open airways in general?
I utilize them both. I actually use percutaneous trach quite a bit in the ICU. It's almost more of a matter of convenience than that I think it's a better or worse technique. It's just, finding OR time, especially maybe at the end of a day or on a weekend when we're trying to get a trach done. I have good cooperation with the ICU doc to run the bronch during a So I find it a useful technique. I think you have to be careful. There's little things about percutaneous trachs that you have to be aware of. In my opinion, there's certainly a higher risk of kind of indenting that anterior tracheal wall cartilage and maybe leading to a higher risk of a long-term upper tracheal stenosis. So your technique, I think, matters. As you're dilating, inserting your trach, making sure that you're happy with how it's sitting in there. If it's really indented and narrowing when you put the trach in, there's a reasonable chance that's how it's going to heal. And at decannulation, that patient might have a tougher time. So I think you have to, really have good technique when you're doing it. But I think it can be a useful time saver, if nothing else, and just kind of get a patient moved through tracheostomy sooner. And then, of course, just knowing, the patient that maybe isn't a good candidate for perc trach, there's a variety of reasons out there. It's all in the literature about, when to do it, when not to do it. But I find it a useful technique.
Just my last thought on that is I agree with Kyle. I think the anterior wall collapse, if you would, that sometimes is associated with perc trach, I think that's something that gets overlooked even in a lot of the articles. And I think a lot of times the follow-up on these patients, I think a lot of these patients that have perc trachs, and then if they are not decannulated in the hospital to where you would realize there's a problem, that it just really becomes a major issue.
Thanks. Just to move on a little bit in the interest of time. So we've got a nice chapter here in dysphagia, and granted, it's certainly written from a proximal esophageal or an upper aerodigestive format, which is perfect for this issue. Some colleagues, friends of ours, John Federico, recently put out an issue on esophageal surgery we worked with just before we started doing the podcast. But we covered a lot of the other esophageal motility issues. But so dysphagia, I usually think of structural versus functional issues, and the functionals are largely motility, although that term may not be completely inclusive for all this. But, what's your general thoughts regarding the person who comes in with difficulty swallowing or other symptoms of proximal esophageal concern? How do you generally approach these?
Well, I think, one, you're trying to identify the pathology that you could address surgically. I think, that's often, patients are being sent to us, obviously, for surgical opinions. We certainly offer medical advice too, but that's, number one, we're trying to, rule out serious things that may require serious intervention, upper esophageal cancers, hypopharyngeal cancers, diverticula, strictures. So we're visualizing these patients in clinic, flexible laryngoscopy for us. It's not uncommon that the dysphagia patient, we scope them. We don't really see much in the hypopharynx, maybe a little bit of secretions pooling. That progresses on to probably an evaluation of the remainder of the esophagus through, the transnasal esophagoscopy is done in some centers, or we refer them to gastroenterology for an EGD. A swallow study, all these things are done to identify, is there a stricture? Is there a mass? Is there a diverticulum? Something we can address surgically, or that should be addressed surgically. And obviously, if we find that, then it kind of takes them down that algorithm. The functional patient that's certainly a tougher one in my experience. It's not uncommon that patients with symptoms of solid food dysphagia, food gets stuck, on occasion. This workup sometimes this initial workup, I should say, doesn't often yield a lot. Our scope looks pretty normal. The GI scope, looks pretty normal. We get a swallow study. It shows some issues with pharyngeal coordination, but no obvious strictures, no obvious diverticulum. And those are certainly tougher patients to help. Now what? There's supplementing studies like manometry, which is looking at esophageal muscle function. It's sometimes a question of what do you do with these results? So we have a patient with abnormal manometry. They're not progressing the food down their esophagus very well. What do we do with that? In a lot of cases in medicine, our ability to diagnose things far outpaces our ability to fix things. But this is, I think, we're having good collaboration with your speech therapist. Those are people we lean on heavily for these patients that have functional dysphagia. And sometimes just having somebody meet with these patients on a semi-regular basis, give them tips, give them reassurance that, hey, things are going okay here. That can be as beneficial as anything.
Yeah. So a fair chunk of the chapter looks into cricopharyngeal dysmotility. And, I've been around long enough when, if you include Zenker's in sort of that quasi category of cricopharyngeal dysmotility and inferior constrictor, commenting to find your problems. I mean, we've gone from the open era with diverticulectomy, diverticulopexy, then we progressed into the stapled era of dividing these. Now, we certainly got some medical options for some of these, maybe not Zenker's so much, but Botox. So any comments or thoughts for our viewership about these various options?
Yeah. So that patient who truly has upper esophageal achalasia. So we get a swallow study, they're tight at that sphincter. Like maybe we get manometry and they're tight there. Number one, like I always have to step back and say, why are they tight? And these are patients that I usually kind of take a slow walk through the treatment with. I'm not going to jump right to an aggressive treatment. And I would consider certainly cricopharyngeal myotomy is our most aggressive treatment in this patient. But Botox is kind of right there. It's a similar treatment, just short lasting. So these are patients that I'm almost always going to, if they have not tried like a prolonged course of anti-reflux therapy, I'm going to try that. Sometimes we see this upper esophageal tightening, a response to reflux. So I think if there's no contraindication, if they haven't tried it, a good start with anti-reflux therapy. Visiting with a speech therapist is always kind of early in the algorithm on these patients. From there, if they're not getting benefit from those kinds of things, I will typically offer that patient just an initial dilation of their upper sphincter. There's a couple. This is helpful both therapeutic and diagnostic. So, the typical finding, at least in my hands, is that we go in and we find the sphincter looks fairly normal and it's fairly pliable. It dilates pretty easily. This isn't a stricture issue. This is a functional issue, but the dilation will, even in these patients, will often give them some temporary improvement. It kind of stretches it, maybe resets it a little bit and decreases the hyperfunction. And so that's helpful to know, hey, if we weaken that muscle or we stretch that muscle, does the patient actually feel better? Not all of them do. There are some patients who we go in and stretch that muscle and it doesn't seem to make a huge difference. And those are patients I'm going to be much less inclined to kind of take through more aggressive treatments like Botox or cricopharyngeal myotomy, because, when we start talking about those in a minute here, those certainly have downsides. Stretching has very little downsides for most people. So if you give them a stretch for me, I use a balloon dilator, one of those Boston Scientific 18, 19, 20 millimeter balloon dilators. They stretch up to 20 pretty easily typically. If that patient over the next few weeks says, wow, I'm swallowing better, this is nice, that helps me. Okay, now I know if I weaken this muscle, I'm probably going to help this patient and hopefully not make them worse. So an initial stretch is what I typically offer that patient. And there's a few patients that just a stretch gives them some long-term improvement. Maybe there is some quote unquote resetting of the muscle function there. But if it helps for a while and then they get worse again, now I will have the discussion about Botox with them. It's described in the article a little bit, and there's other articles that talk about it in our literature, but essentially expose that muscle endoscopically, use a needle and just inject Botox into usually like 3 or 4 quadrants of the muscle and weaken it. Now, one thing that patients have to be warned about is by weakening the muscle, we almost always are going to help things pass down easier, but we're also going to allow things to pass up easier. So belching, reflux, kind of a gurgling sensation. These are all potential side effects of Botox. And I've seen those in patients, and those can certainly be annoying side effects in some patients. So if we put a patient through Botox and they have these side effects that they aren't thrilled with, I'm certainly not going to offer that patient a cricopharyngeal myotomy, because now I'm making all those side effects potentially permanent. But if Botox is helpful and there aren't negative side effects, and it is it has the predictive time course, meaning in 3-4 months it gets worse again, now we can have like a serious discussion about cricopharyngeal myotomy, whether open or endoscopic. So, but these are patients I certainly kind of take a slow walk down the treatment pathway because there are steps along the way that could make them worse.
Yeah, that sounds like a very prudent approach to me. And I think you're right. It's one of the things in surgery you have to know is what you can't take back. So realizing when you can make interventions that are temporary but also diagnostic is a super useful basic surgical principle. I want to move on a little bit to the hyperparathyroid section. The doctors Hunt and Slattery wrote this for us. It's a wonderful chapter. Hyperparathyroidism has been a darling of every surgical professor, every board's examiner, every written test any resident or fellow ever took. This is one that gets tons of traction. There's probably more people that have studied up about it than will ever have it, but still a lot of people get it. So it's a good thing to know. So, for a long time, we've understood the relationship between ionized calcium and parathormone. Bone loss, I think, has become, and some of the other symptoms that are a little harder to measure have become much more prominent in the last 20, 25 years anyway. But sort of, we've moved the goalposts on this a little bit from the early days to where we're getting closer and closer to normal values with some symptoms, and we'll still consider operative management. So I'm wondering if you guys want to give me your kind of over your 30,000 foot view of at least primary hyperparathyroidism, and you can put the caveats for others in there.
I think the biggest thing I found that's helpful with parathyroid surgery is to encourage people to either seek out a high volume practice, so to speak, that they're going to really devote themselves to this disease process and the surgical treatment, or they should probably just choose a different designee in their community or region, to be that person, if you would. I have been the high volume parathyroid guy. We'll do in the vicinity of 100 cases a year where I'm at. And it's a humbling disease process, because when it is easily localizing single gland disease that sticks out like a sore thumb on imaging, and you go to surgery, you find it within minutes, you take it out, the levels drop, substantially to where it's unequivocal, this appears to be single gland disease. It's very rewarding surgery. I think where it gets tougher is when you have what I refer to the residents as occult multi-gland disease, which very commonly has imaging studies that show a suspect abnormal gland, but you get an insufficient drop in PTH, or occasionally you'll even take out the enlarged parathyroid gland that's noted on imaging, and your PTH will go up. And you're like, whoa, what's going on here? And they touch on this in the article, is that the intraoperative blood work it's a guideline, but it's not a guarantee. And I think if you do enough parathyroid surgery, I'm sure Kyle is good enough. He's never seen this, but I've seen it, unfortunately in the last few months, even on a patient where this patient started with a preoperative PTH of 200. The way I do it, I check the level at 10 minutes and 20 minutes, and I'm looking for a negative slope. There's been several publications that looked at if you continue to have a drop between 10 and 20 minutes, it was even more predictive of resolution. And this lady did. She dropped to 45 and then dropped to 32. And indeed, her calcium came down, her PTH stayed down, but she's still hovering with a calcium of about 10.1, and her PTH is about 70 now, 2 months out from surgery, which that's telling me she almost assuredly has a lesser secreting, secondary gland that's causing it. So it's an incomplete correction. So it's better than a failed exploration, which is your worst nightmare. But in this case, it's definitely just illustrates it can be a very tricky problem. That's kind of my 2 cents. Is if you're going to do it, I think you're really kind of be deep into the pool, so to speak, rather than kind of I think there's just, it's concerning to be a parathyroid dabbler would be my kind of gray haired soapbox.
Because I totally agree with Brian. I have kind of 2 thoughts about parathyroid disease. One, we're seeing patients earlier and earlier in the disease process, right? It is now very, very common, at least in my community, and I feel like in most, for a primary care doctor to get a PTH level, the first hint that the calcium is high or even high end of normal, or if a patient has symptoms. We all know that, patients with hyperparathyroidism, they often feel crummy, for lack of a better term. And it's not uncommon now for a PTH level to be drawn even in the setting of a normal calcium. So we're finding patients earlier and earlier in the disease process. It's a bit more of a diagnostic dilemma of, does this patient truly have primary hyperparathyroidism? What's their symptomatology? Is it enough to warrant surgery? So, that's number one. The era of finding patients with a calcium of 13 and a 2.5 centimeter adenoma, you don't see that very much anymore. Like, those patients have now all been discovered years before. It's, in my experience, at least, it's very rare that we find that kind of home run case, so to speak. And two, I think anybody who does a lot of parathyroid surgery, I think Brian would agree with me, we're often quoted in our training this idea that single gland adenoma is 80+% of cases, and then there's double adenomas, there's 4-gland disease. I think anybody who does a lot of parathyroid surgery would agree that the case of multi-gland disease is much, much higher than we were taught. There is a lot of multi-gland disease out there, and we just have to be kind of ready to deal with it. I think these days, if you're going to do parathyroid surgery, you have to be ready and willing to do 4-gland explorations a lot. And that's okay. There's nothing wrong with that. It's kind of, in some ways, it's the field has kind of gone full circle. 4-gland explorations were the standard years ago. And then over time is this thought process about single gland adenomas being the vast majority, and the whole idea of doing, smaller incisions, mini parathyroid, less invasive parathyroid surgery. And that's still appropriate in some patients. But I think if you're going to be a parathyroid surgeon, you have to be ready to do 4-gland explorations. You have to know where to look. You have to be comfortable working around the recurrent laryngeal nerve. You have to be comfortable with managing coexistent thyroid disease, nodules, because you're going to be working around sometimes big nodules, big goiters. So I totally agree. It's not something probably to be dabbled in these days. You kind of have to be ready to manage these more difficult cases. And this is, I think, again, anybody who does parathyroid surgery gets humbled by it. It's these, I often, tell students, residents, that these are the best cases or the worst cases. There's kind of nothing in between. They are, as Brian said, you get these home run cases, and then there's a lot of there's dilemma cases. I had one today. You have 4 glands, mildly enlarged, one of them bigger than the other 3, but all 3 of them a bit, and it's always a question of, okay, how many do we take? How much do we rely on the intraoperative PTH in making that decision? And this is a discussion I have with patients preoperatively too, is, we have to be ready for the possibility of 4-gland disease and what that means and how we manage it. I want to improve your PTH and improve your calcium enough to bring you down to a safe level. I don't want to make you hypoparathyroid. That can be a more difficult problem to deal with in a lot of ways. So just, I think appropriate counseling with your patients preoperatively is important too. In the past, and even in my residency, even there was maybe this tendency of, we're going to find your gland and take it out and you're going to be fixed. And that's awesome when it happens. But you also, I think, have to counsel patients that this is sometimes not a problem that we completely fix with surgery, that we might, we manage with surgery. We help it with surgery. But patients have to kind of have a good understanding of the disease process before surgery.
Well, that all brings me up to where I was going to ask you next. And as you say, I think everything number one, I'm not aware of too many problems in surgery that aren't humbling at some level. But this is certainly among them. And it's, as you say, there's easy, hard, and there's miserable. But, when I was a lot younger, ironically, I wound up doing a fellowship on mostly pancreatic surgery, doing more redo parathyroidectomies than I did pancreatectomies. And I did a lot of pancreatectomies. But we just happened to have a referral base for that. And you found out that, the adage is the most important localizing study for parathyroid disease is to localize a surgeon who knows how to operate on parathyroids. And there's still probably a lot of truth to that. But as you say, we've gone through trying to downsize it, rely on imaging technique and other things to make it a much more limited operation. But as you allude to, that the amount of people that have more than a single gland disease, or it's not as black and white as our textbooks have traditionally taught us, is quite unnerving. Hopefully not literally. But so, give us some thoughts, if you don't mind, on, when you're once you've decided somebody has proper hyperparathyroidism, and you want to figure out how you're going to image them, how you're going to assess them, how you're going to start things out. What are your feelings about imaging process, either radionuclide studies, ultrasound, MR, 4D CT? What are your preferences?
Yeah. So at least at our center, what we do is we consider all of our potential thyroid surgery patients as possibly having hyperpara. They're all screened for hyperpara so that we don't have a thyroidectomy. And then you find out the hard way in their postoperative management of checking for hypoparathyroidism. Oh, geez, Louise, we check our post-op PTH, it's 200. And so we screen them that way on all the thyroid patients. Now, vice versa, with all of our parathyroid patients, they all get a thyroid ultrasound because there's a high propensity of these people that have synchronous thyroid nodularity. And I would say probably 30% of our parathyroid surgery patients get synchronous thyroid surgery for one reason or another. And so we start with thyroid ultrasound. I think each institution, I think it's wise, if you're going to do a lot of parathyroid surgery or try to build a parathyroid surgery program, you want to know how good is the equipment that you have, particularly with nuclear medicine, because the quality of those scanners is all over the board. And that in turn is going to affect the reliability. And I think you want to know who are the radiologists that are doing it. At least in our program, nothing made us more successful as parathyroid surgeons than paring down our parathyroid imaging to one or two radiologists total. And then we had what we called a pre-surgical parathyroid board that I kind of concocted, analogous to like a tumor board, where we would re-look at those imaging, myself and then my partner surgeon who also had a busy endocrine practice. And we would look at that with the guy that we thought was the best in our community for head and neck radiology. And he really got better and better over a several year period himself at interpreting the scans. And so we would do a SPECT nuclear scan that's got a CT overlap on the nuclear study, in addition to the 4D, so to speak, parathyroid protocol CT. And then that was on top of ultrasound that was either surgeon-directed ultrasound in the clinic, if that was totally benign, if it was any form of thyroid nodularity and so forth, then we'd have an official ultrasound done, particularly for patients that needed to have nodules followed long-term. So that's been an algorithm for me that has been successful. I think tailoring your desired imaging to the skill set you have in terms of the equipment that's available at your hospital or institution and community, and who's the interpreting radiologists. These scans are tricky to look at, and I guarantee you, Kyle thinks like I do, that both of us have been humbled by imaging findings that were really a quandary. I think having a condensed series for that radiologist where he's reading these same scans over and over. And if you really want to get fancy with that, you can do a retrospective, which we did, where we looked at our operative findings and then compared those in hindsight to our pre-op decision-making, where we would say, here is our suspect gland 1, 2, etc. And we would look at that at the time of surgery and say, okay, were we right? Was it single gland disease when the imaging suggested? Was the abnormal gland in question in the location we thought? And then you can kind of inform yourself over time. At an academic center, you know what I mean? You collect that data and likely publish it. I think just even in community-based settings, you can keep that data informally, and then you get a much better idea and sort of a better confidence. And I think these things are really good for patients because it's really condensing the experience of everybody that's involved in it. And the same thing goes for the experience of the endocrinologists that are helping you with these patients if you're lucky to have a good endocrinologist in the community. Yeah, that retrospective look is awesome. Yeah, I mean that, and all, always if you have these preoperative imaging studies, after surgery, going back retrospectively and looking, okay, what I thought was it, was it a lymph node? What does that look like on the scan? I mean, all that is so useful for education going forward. We use here, I use in-office ultrasound that I perform on patients. And the more of that, like anything, the more that you do, the more confident you become in using it. And just like Brian, we're examining for thyroid nodules at the same time. There's further workup need to be done on those. We utilize 4D CT. We've used less and less system maybe over the years. And part of that has to do with our radiologists, I think, just not
liking the technique as much, and maybe we're not. They didn't find it as useful, and I don't find it as useful, so we've kind of quit using it. I do think it's important, for that some patients with ultrasound, you can have a pretty high degree of confidence that what you're looking at is an enlarged parathyroid gland. In the patient, you don't find that. I do still think it's important to have some type of imaging modality that rules out that that mediastinal adenoma. It's rare, but those are the ones you obviously don't want to get caught with your pants down at the time of surgery. So I still think it's useful to have some type of imaging modality to rule that out. I don't know what your thoughts are on that, Brian, whether that's CT or SESTA maybe.
I completely agree. And a lot of the dual imaging where these are complementary studies, you're really just trying to increase your yield, especially if you're doing a high volume of patients per year. You're wanting to catch the outliers. And so it's almost like finer holes in the fishing net, if you would, when you're simply going to catch more fish. I think that particularly in patients that have what I call negative imaging, meaning you're looking at the imaging, you really don't have a clue where it's coming from. I think those are really patients you need to scrutinize that for that being the oddball ectopic gland. And that's the person where I think thyroid ultrasound especially comes into handy, because if a person has an intrathyroidal parathyroid gland, which that's probably talked about more often than it happens, but it certainly does occur. A lot of times you're going to find that with ultrasound, or you're going to get enhancement in that thyroid lobe on the nuclear scan, just leading you to sort of like, okay, we'll start with 4-gland exploration on this non-localizing person. And if everything else looks normal, then we'll have them consented for, thyroid lobectomy. And then I bisect that on the back table myself and have it confirmed by Frozen when I've got a strong suspicion for intrathyroidal adenoma. But again, you start to get into less common entities when you're talking about truly ectopic glands, intrathyroidal, and so forth. But like with anything in surgery, as you expose yourself to a higher N number, you start to see them.
And I think that, just that experience of cases over and over is, like you said at the very beginning of this, high volume, like it kind of, you can't be emphasized enough that, early in your career doing parathyroid surgery, the quote unquote negative sestamibi, negative 4D CT is what you're most concerned about. As you gain experience in the technique, I think that becomes less and less daunting. You've kind of convinced yourself, okay, it's not in the chest. I can find it in the neck. I know where to go in the neck to look. And so I think just that, again, that volume of cases is really big. I think, and I think appropriately, some surgeons, especially if you're low volume, you have a negative localizing study, you might be hesitant to operate on that patient. That's an understandable hesitation and appropriate if you're not doing a ton of these cases, but I think for the high volume surgeon, it doesn't have to mean that you have to be any less confident about your ability at surgery.
I think that's well said, Kyle. And I think you're just kind of setting yourself up for how difficult is this case going to be? Am I going to devote some more time to this in the OR? Am I going to operate with a co-surgeon on non-localizing scans, at least at our center, where we have a pretty robust endocrine volume for both thyroid and parathyroid? That's just the protocol that we came up with ourselves because it's a stress reducer for the surgeon. If 2 eyes don't see it, almost always 4 eyes will. So our non-localizing scans, we just have a particular day per month where those patients are stacked and we'll just operate together. And then it kind of becomes a bit, rather than being you're sweaty and it's stressful, at the end of it, it actually becomes fun. You've got more conversation and banter. Each person is exploring the opposite side, but you do have that confirmation of 2 guys or ladies for that matter, working at once. And I think it imbues a lot more confidence to tackle these a bit more difficult cases. I know you and I, both Kyle, have practices that are in kind of isolated geographic areas. So if somebody's going to leave the region to have this dealt with at a bigger center, they're going to have a 4, 5, 6 hour drive in a car. And so I think building these things within your own community where you're kind of exploiting the assets that you have available to you makes a lot of sense. And I think it's a real service to patients. And I think this also applies to our colleagues that are in other countries that may not have access, to some of these advanced imaging modalities. And maybe they just have ultrasound and their own instincts. And I think you could sort of make do. mean, I think a lot of patients you can look with ultrasound and see yourself as the surgeon, where there's suspect glandular disease. And then hopefully if you've got a co-surgeon in the community, you could sort of set up your own program, if you would, to kind of mimic these same modalities, but without maybe all the bells and whistles.
So fellas, in the last couple of minutes that we have here, we've got an article in this issue of yours from Dr. Sand on the online physician image, which is, to the best of my knowledge, in the almost 20 years or so I've been running this, is a new one for us. I think we're off onto a new departure, and a very timely departure. And I mean, as we look through it, I mean, different people have different levels of social media savvy, but I mean, it's potentially a tool for patients. It's potentially a tool for doctors to either promote themselves or state their case for what they're there to provide for the community. It's a tool for hospitals and organizations to market and educate. But in the long run, a lot of this stuff becomes perception, and whether perception reflects the reality that we all agree upon isn't always the case. So what are your thoughts on where we are with online?
Yeah, I'll jump. You betcha, I'll jump in, because I had specifically asked Dr. Sand to submit this because he's a definite expert both in our region and nationally on this topic. He's got a background in having a cosmetic portion of his practice as a facial plastic and reconstructive surgeon, and so that kind of, I think the cosmetic and aesthetic crowd, kind of jumped onto this thought process a lot earlier, because they're doing direct-to-consumer marketing, where a lot of us are seeing, mainly referrals from other patients as opposed to direct reviews. And he does a great job of pointing out in the article kind of the changing tides that includes both opinions of hospitals and insurers. And that for a lot of us, even though this may be a topic that's not our favorite, we're probably he kind of lays out three different types of doctors and their general views towards this. And I think the last one that he gives is that those physicians who have an awareness and they actually take action to understand their online presence and online reviews, and actually come up with a plan and understand how you can actually change that, especially for the better, if you've had, if you've been victim of some middling or negative reviews. And so I think it's a timely topic. I think it is going to be a necessity as we move forward. And I think it is very possible that our jobs may depend on it in some form or fashion. I know I recently just left a large private practice of 30 surgeons and became an employed doc myself. And, in the last 2 or 3 years, when I was in practice with Dr. Sand in the large group, this was something we paid closer attention to, because it was getting a lot of attention. And across 30 surgeons, you had each of these types of mindset that Dr. Sand lays out in the article in terms of awareness. On one extreme, a lot of times you'd have older docs that didn't know anything about the online review and they didn't have any intention of figuring it out, versus guys that were coming out of residency. And that was questions they were asking in the interview was, how is this practice going to help me build an online presence? And in turn, continue my reputation, because this is really on their mindsets. And they kind of understand, especially if they ever decide to change jobs, that kind of goes with you, even if you move states or move cities. And so hopefully readers will enjoy the article. I would really encourage everybody to read that one. I know sometimes when it's the non-clinical article in the journal, we kind of want to look over that one. But I think just like when you stumble upon the really good articles on physician finance and money management, at least that's an increasing topic here in the States as well. I think you can get a lot of personal good that sometimes helps you as much as anything else in the issue.
Yeah, this was a very educational thing for me. There's no doubt I fell in the number one category: do not know about their online image and do not care to know about it. And I'm probably not alone in that. But I think one thing that this really made me think about was, we have to have humility in our jobs, and obviously there's feedback that can come back through social media that's maybe not fair, not accurate. That happens, and that's definitely where we have to know the strategies of how to manage those things when they happen. But at the same time, it's a reminder to me that we also have to have humility in our job to know that just because we thought a certain patient interaction went fine, they might not have viewed it the same way. And it's important for me to take that feedback and try to get better. And that's how we're going to continually improve. I mean, we do that in other aspects of our job, right? We were just talking about that in parathyroid surgery, for instance. We retrospectively review the images in our surgery and what we did and what could we have done different. I mean, hopefully we're doing that on a constant basis. But this is just another method for that, a method for us to improve a lot of this has to do with our interactions with patients, right? Like oftentimes the way we're perceived by a patient has, in some ways, can have nothing to do with our skill as a clinician or as a surgeon, and have everything to do with our interpersonal skills and being able to help a person through this illness and help them feel listened to and cared about. And that's another part of our profession. I think it's important that we get better at. And so this was definitely a reminder to me that, hey, you can't just bury your head in the sand about this. It's important to learn from it and hopefully get better.
Well, I think, these comments and going back to some of the earlier comments on understanding patient goals regarding being trached, reminds me of something some of my early professors told me. The most important thing about patient care is actually caring for the patients. And that means understanding, what they want out of the interaction. And you're right, not occasionally what somebody wants out of the interaction isn't what they should get, like, the opioid seeker or something. And certainly in my administrative jobs, I've had a lot of people make negative assertions about physicians because they didn't give them what they wanted as opposed to what they needed. But I think overall, your comments, Kyle, are spot on, that it's an opportunity to see how it went from the other side. And when the feedback's fair and honest, that's when it's super helpful. But you've always, we all take the most hurtful comments, and it's sometimes hard to hear, but I think you're spot on. I want to thank both of you guys for putting together a really great issue. This is, it's one of the areas where general surgeons really need good advice. You guys have certainly upped the game from the way it was when I was younger and people dabbled in this a little at a time. And you two in particular have done a really spectacular job, both clinically and with putting together this series for us. Any final comments for us before we kind of let John sign us off? Or?
Just want to say thanks to Brian. I've known Brian for several years now, and he's certainly somebody that I look to for advice and for help, and any chance I have to work with him, I really appreciate. So thank you, Brian.
And vice versa, Kyle. I appreciate those kind comments, and the same thing goes to you. It was a joy to do the issue, and just as much of a joy to do the podcast. I think this is a format. I know I listen to podcasts every morning on my commute, and again in the afternoon. So hopefully this will at least have a tiny pearl of wisdom out there for someone. And we appreciate folks at Elsevier for helping us put this out there.
Yeah, and thanks to all our authors. Really, a lot of they put in a lot of work with these articles, so we really appreciate them.
Absolutely, yeah. That should have been my first comment. Thank you to everybody. It's hard to practice and publish, and it's a real sacrifice when people.
Well, thanks, guys. I really appreciate everything you've done for us and the opportunity I've had to spend with you along the way on this project and other ventures. And wish you nothing but the best. Thanks again.
Thanks, Ron.
Thank you for joining us for this Surgical Clinics podcast devoted to the April 2022 issue on head and neck surgery, volume 102, number 2. The series is available for individual print subscription with concurrent online access or individual online only access. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter at Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, Stitcher, and Amazon Music. Thanks for listening.